So we're really excited to introduce Dr. Kameron Matthews. As Assistant Undersecretary for Health for Clinical Services, Dr. Kameron Matthews is the Chief Medical Officer of the Veterans Health Administration. She formerly served as the Assistant Undersecretary of Health for Community Care, where she was responsible for the community-based provider network that expanded veteran access to care. Dr. Matthews is a board-certified family physician, as will Reese and I be, advocate and policymaker with a career focus on underserved patient populations. She joined the VA in 2016 after multiple leadership roles in Chicago, Illinois, in correctional medicine, federally qualified health centers, and managed care. She is a member of the board of directors of the National Quality Forum, a member of the advisory board of National Minority Quality Forum, and a member of the Diversity and Inclusion Committee of the Accreditation Council for Graduate Medical Education, also known as ACGME. She serves as a 2018 to 2020 National Academy of Medicine James C. Puffer American Board of Family Medicine Fellow and was elected to the Academy as a member in 2020. She is honored to have been awarded the 2017 National Minority Quality Forum 40 Under 40 Leaders in Minority Health. As a passion outside of work, she co-directs the Tour for Diversity in Medicine, an initiative seeking to bring pre-medical enrichment activities to underrepresented minority high school and college students across the country. Thank you for being here, Dr. Matthews. Having a bit of trouble hearing you.
Double muted, phone and on Zoom. Can you hear me now?
Yeah,
sounds good. There we go. All right, sorry guys. All right, let me go ahead and just start sharing so I can get away from all the technology stuff and just actually have a conversation. Thank you, Kelly, for reaching out and organizing. I'm pretty excited to have this conversation to talk about what I do and what we do, more importantly, at the VA, because it's actually something I personally had no real exposure to in all of my training, and really to highlight it, to honestly, I'll put the bottom line up front, to recruit every single one of you. Like, I'm not even trying to be sideways about this. I think there's a lot of benefit behind working in a system such as the VA, and there are very few of them that really offer the same level of services that we do, as well as the same level of experiences from a provider standpoint. So just again, kind of highlighting my past experience, I came into the VA really excited to treat yet another vulnerable population. That was actually how I approached it. Starting off after residency in correctional medicine, then moving to a couple of different federally qualified health centers. I was initially moving to DC for personal reasons, to be closer to family, but to also look into another FQHC, to be honest. I absolutely love that space. I am still fully supportive and always looking for ways for VA to partner with different community health centers around the country. But the VA stood out as a massive health system in which I was able to get some footing through its managed care department. That's what community care is. And so my eagerness to kind of get involved in a health system such as this really was just new for me. And I literally found the position on LinkedIn. So hopefully I can connect you guys a little bit more personally than just a random social media click. But the really experience has turned into one that I thought I never could have imagined would happen. And to be honest, most of my career has actually been to that level of serendipity, as far as just kind of happening upon great experiences. But separate from that sort of personal track, I also am pretty proud in what I personally, and then what we as a leadership have been able to do in the VA just in the past 4 years since I started in 2016. So just moving ahead, I'm going to give you a little bit of an introduction on the department itself, what we have actually done with regard to a response to COVID. I'm going to dig into a little bit of our DE&I issues, as I have been proud to take some leadership roles there, and then just close it out and hopefully leave a little bit of time for questions. I'll try to rush through this, but there's a lot of information. I cut out a bunch too, so hopefully we'll see. All right, so who we are. It's actually something I am proud to say is quite historical as far as the Department of Veterans Affairs. Of course, President Lincoln was the one that gave us our initial model, but it's also quite historical. And I am not shy to share this now that we're in this new administration, that we are actually questioning what the model of the department is moving forward. If you recognize from the actual language, it's obviously quite restrictive, you know, obviously with a very male focus. And our current secretary, as well as with the support of the White House, is actually looking for the first time to really amend that model, regardless of, you know, how historical the initial was. But really, from there, you expand more than just for the care of the veteran themselves, but 3 additional missions, which are worth recognizing, that we indeed have a mission. It is part of our purpose to not only train personnel within our system, but train, honestly, and maybe even some of you will have this experience, a large proportion of just graduate medical education for the United States, as well as the non-physician workforce. We're talking psychology, dentistry, nursing. I mean, every pretty much, I think we have 2,200 programs, I mean, across the full health system. Now, that in and of itself, you know, at times really allows us to really go in a direction, I think, unlike other health systems, just because we're trying to weigh all of those different academic relationships, as well as our care delivery system. But it's a clear benefit. I myself came through VA 2 different times during residency. Research, a good amount of research actually comes out of the VA, but it's actually part of our mission in that we are trying to actually improve health outcomes. And part of that is actually to not only research new services, but also be innovative in that. And there's a great deal of innovation going on. 3D printing is the latest one that comes to mind that has been phenomenal under COVID response, that we actually started printing out masks and the like. We're going to start printing out some dental implants and things like that, where we're actually going to take on a manufacturer's role, which is pretty interesting and exciting. And then lastly, and I'll get into this, emergency response. We, unknown to others, we actually call this our 4th mission. We are actually responsible, along with other portions of the federal government, usually FEMA just jumps to mind, and maybe a little bit of DOD, right? Or national, DOD is active service members, as opposed to veterans, the VA. Trust me, I didn't know that, so don't be shy if you didn't know. But there's actually, we are tied with DOD and FEMA to actually respond to public health needs. And actually, we've invoked that a great amount of times over the past year. And I'll get into that. Our 4th mission work during COVID, where we're actually accepting non-veterans into our hospitals. We're sending workforce out to nursing homes and hospitals to assist as well. We've done a lot with the First Nations. This is actually something that we're quite proud of and fortunate enough to have that infrastructure where other health systems may not. All right, sorry, I don't know why it's not clicking. So what do we mean when we call ourselves the largest integrated health care system? I mean, over 1,200 facilities in the health system as it stands. We really do look at ourselves as more than just a healthcare system, to be honest. I look at it as we are integrating ourselves across all of the different services that VA provides. So we are Veterans Health Administration, but of course there's Veterans Benefits Administration. So you've heard of the GI Bill, you've heard of other benefits that veterans are able to receive. We actually look at that as part of the healthcare system that we provide. And we really, I think, are at the lead when we're talking about providing services to address social determinants of health and well-being, where other health systems are maybe, you know, in that place where they're either organizing that maybe through some full risk contract that they have, that they get paid to do certain things, or they're pulling in, you know, bits and pieces. Yes, there's some emergency rooms out there that are doing, you know, housing coverage, and of course there's food pantries and all of that. We actually look at this as part of our health system and have for some time. So when we are really trying to make sure we're addressing the full lifespan and full set of needs of veterans. That's actually part of what we consider to be our responsibility. Few more numbers. Most people don't know that off the top, we have about 21 million veterans in the country as a whole. More than 9, so not even half of them are actually enrolled with the VA. Any number of reasons. Some of them may not be necessarily choosing to come with us. Some of them may not be eligible. Enrollment in the VA is not automatic when becoming a veteran, and a lot of times it is either based on your time of service, so what war or era you served in, or income level. So it is not necessarily an open system for all veterans, but we are continually trying to reach out to reach those veterans that may be eligible for our services. And we are not at that number as of yet. Of the more than 6 million veterans enrolled, about 9 million that are enrolled, only about 6 million use our services. So we do have some room for growth there. But of our 3 priorities there, that restoring trust is the one piece that maybe you realize is something that we are working on the most there to really increase those veterans that are seeking out our services. Of course, historically, there's been plenty of reasons, unfortunately, some of them true, some of them not, where veterans may not really be interested in seeking out our services, but we're really focused on that as a priority within the Veterans Health Administration. All right, can I just click? There we go. So just a couple of more numbers so you know the scope. We have about 170 medical centers nationwide. We're broken up into 18 regions. We complete just about 60 million appointments a year. I mean, this is a massive effort, obviously, when you're thinking about the number of resources that this takes, the workforce that this requires, more than 850,000 providers in our network. That's our network even outside of the VA, of what we work with in-house, 100,000 or so providers in-house. And then we have in community care, that managed care piece that I mentioned, we have close to 1 million, I think now, of providers that we also work with. Integration of a health system is also not just about what we're doing in-house, how we're able to connect between facility to facility and region to region, but also how much we integrate and perhaps are interoperable with those providers in the community. Veterans do not need care segmented in different ways. Oh, I get care over here and then over here. And we know that happens in U.S. healthcare system a lot, where different patients are picking and choosing, appropriately so. Sometimes it's due to relationships, sometimes it's due to their health insurance, right? What we're really about is making sure that we're at the center of that care. So no matter where veterans are receiving that care, we're actually coordinating it and appropriately integrating all of those services with the veteran at the forefront of that care. So what have we been focused on really, honestly, since 2014, if any of you had heard what we call the access crisis in Phoenix, Arizona, where there was unfortunate a great deal of publicity around a number of veterans dying, unfortunately, while they were waiting for oncology care. This was due to the fact that we didn't have enough services in-house and they weren't referred to services outside of the network. You can imagine in other payer systems, private sector, if you don't have it available in the network, you're able to be sent out. We otherwise, as a closed system at the time, did not have a full development of how services could be received in the community. And unfortunately, there was a lot of discrepancies and inconsistency. And unfortunately, in Phoenix, that really came to a head where they were not referring out. So in 2015 is when the Choice Act was passed. I had the pleasure of running that when I came into the VA in 2016, and it left a lot to be desired. It was not really structured as a real managed care program might be. Thankfully, in 2018, we replaced the structure of the Choice program with requirements that we developed under the Mission Act. So it's not the Mission program, but we got the requirements from the Mission Act. And we're really able to expand eligibility, defining when a veteran might be referred out to the network. So it's not an open network in the same way other managed care programs are. Veterans have to be deemed eligible to receive care in the community. So actually, I have a slide on that. I'll go into that. Other forms of access within our facilities, we're really actually leading the way as far as transparency of really sharing useful information on the line of when veterans would be waiting for care. And typically in the private sector, that's really only visible. Maybe what you see in those billboards about emergency rooms, right? Wait time of 30 minutes or so. Our Access to Care website actually provides the wait times for all of our services, just to provide that transparency so veterans can make the choice if indeed they have coverage to go to another system or they're eligible for community care and need to make that decision about whether they stay in-house or get referred out. Really trying to modernize, and in fact, I serve as the VHA functional champion for our Cerner deployment nationwide, which we'll be doing over the next 10 years, which is a massive effort. It is the biggest EHR deployment ever. and through that modernization, we are hoping to really modernize our data strategy as well as our scheduling platforms. Any of these have worked in the VA. Our health system, our EMR, was world renowned when it was created some 30 years ago, but we really haven't gotten to the point of it being fully modernized, and the scheduling system, unfortunately, is a large piece of that. So we're really looking to make sure that while the EHR itself is not going to improve access, that there's a lot of pieces associated with us that will allow us to have some efficiencies in how we administer care. And then through the Mission Act and through other work that we're doing, and definitely based on what we've seen in COVID, we're really trying to make sure we disaggregate how we're looking at care on a national basis and really look at specific underserved communities. So we have designation of certain facilities as underserved under the Mission Act, and therefore they get a little more attention, more quality improvement support, and potentially even more funding. We have a huge component focused on rural health, which in and of itself is of higher impact for veterans, just because veterans have a higher ratio of urban to rural than other populations, and a lot of that having to do sometimes with their actual medical issues, as they're not looking to live in urban communities. And then our telehealth platforms have expanded. We are actually benefit more than, again, the private sector because we're a federal system. We actually have what we call federal supremacy over state law. So the licenses that you have to have per state in order to practice telehealth. So even if you're living, here on the East Coast and you're practicing in California, you have to have a California license because you're actually providing services there and you have to follow state license law. We don't have that. So I actually am based in DC, have a DC license, and actually pre-COVID was able to provide telehealth in California with a DC license because we have that federal supremacy. So it allows us to have consistency across the health system. It also allows us to cross-level services no matter where we are in the country without having to deal with the differentiation between the different state laws. That's a huge issue. On top of that, we're now trying to define different scopes of practice because different states allow different providers to do different things. The biggest one, and actually quite controversial, are CRNAs, our nurse anesthetists, wide-ranging laws across all 50 jurisdictions. And so we are going to be creating one single CRNA definition for VA, and it's causing quite an uproar because, of course, there's a lot of concern there. But this Atlas program that I actually have highlighted here is one where we're moving outside of just telehealth between our clinics and perhaps even the veterans' homes. Sometimes broadband, particularly in rural areas, is a big issue. So we actually have access points in VFWs, in Walmarts around the country, and we'll be expanding other partnerships where we have these pods where veterans can actually go to the pod, connect to their provider at the VA, and have services that way. So we're pretty excited about Atlas and the future expansion to additional sites. Right now, I think we're still at 6 sites, but it'll be growing greatly. So when we talk about kind of making sure that services are as veteran-centric as possible, that's a phrase that we emphasize in every sort of way. We are really trying to bring down those silos of how veterans think about their care, whether it's in VA or in the community. And one of those initiatives that we have in order to do that is through referral coordination and really centralizing in our individual facilities how veterans are referred for care. So it's not up to the provider to have that conversation with the veteran in front of them. Oh, you're going to be referred to this provider in the VA. Oh, you're going to be referred to the community because we don't have it. all I need to do with that veteran is say, you need to see X. And therefore, then the referral coordination team takes it from there, helps figure out community care eligibility, helps them figure out what is the best provider, in fact, to actually see them, what's the most convenient for them, what makes sense, whether it can be telehealth or face-to-face. We have this really hope that this would be empowering the veterans to make those decisions as openly as possible and with the right information, because unfortunately, in the past, the community care work and then the direct VA work had been really siloed. So again, bringing down those walls, making sure veteran care is as much of the focus as possible, and it not just depending on, again, me as a provider saying, oh, I want to refer you over to Dr. Smith. And unfortunately, at times, that's often how it is in private sector or even in academia. You just refer and it's just kind of open-ended, right? You drop a referral in your chart or whatever, and then some team shows up and it's ever rotating and all of that. No, we instead really want these referral coordination teams to assure that the veteran understands how the decision is being made, make sure they're part of that decision, that it's not just this open-ended, oh, we have this available, and that's it, that's your only choice. But no, presenting all of the choice to the veteran so that they're aware and, again, empowered.
So Dr. Matthews, we have a question from the audience.
Oh, sure. Yeah, please.
To be clear, what is then meant by in-network for a provider?
So in-network for, well, we tend not to use that phrase in the VA because we don't necessarily call ourselves the VA network. We usually say direct services or in VA versus in the network, which is called the community care network. So our actual contracted relationships for providers. So if we heard in network, I'd kind of question, did that mean in the VA or did that mean in our community care network? Because there's other providers in the community that are not in our network that they cannot be referred to. So it could mean either or, depending on what someone might be asking.
Okay, so I think the clarification might be if a vet was trying to, or a vet or their family members were trying to access care, where they can access it is dependent on whether or not that provider has a contract with the Veterans Health Administration or direct employees of the Department of Veterans Affairs.
Yes. And then remember, it's not so much just open-ended. They can go see someone in the network. They have to be eligible and actually referred. So we are a bit more of on the HMO side of managed care as opposed to open access or PPO where they can just access the network on their own. They do need official referrals with the exception of mental health or emergency room care. They can access those without direct referral.
Perfect.
Okay, great question. Thanks for letting me clarify too. All right, so I mentioned the Mission Act. This was quite a big deal, not only because it helped us consolidate and really, to be honest, clean up community care, the program I was running the past couple of years. It was a mess, just the regulatory and legislative requirements, the multiple programs. We had about 13 different programs that Congress had defined and different appropriations even. And I won't get into appropriations law, but Congress gives you money, you have to use it for specific reasons. In the VA, we technically have 4 different colors of money, we call them, 4 different appropriations, and you can't mix and mingle. So it was very confusing and definitely did not put the veteran up front as far as what kind of care they needed. And so the Mission Act basically brought down those walls, said, go ahead and define what eligibility you want it to be. If you don't agree with the choice program, which many of us didn't, because choice by law, in the law, in 2015 again, actually defined what eligibility was. And for the years that we had choice, we actually pushed back and said these were arbitrary decisions. And I'll get into that again as well too, I think the very next slide. But with the Mission Act, we were able to define what that eligibility was ourselves. We were able to actually bring quality and the best medical interests of the veteran into account when that was not available under choice either. But Mission Act was so much bigger than community care. It also allowed us to expand the Caregiver program. So Caregiver is actually quite a monumental piece that not a lot of payers have as well too, where we actually provide financial assistance to formally approved caregivers of veterans. It was initially just for Iraq and Afghanistan veterans. Now it's been expanded to all Arabs. under the Mission Act. Well, the Mission Act gave us the requirement that we could go ahead and expand, and we then had to define it by regulation. The Asset and Infrastructure Review, the AIR Commission, is a huge piece as well too, looking at the footprint of the VA. Most of our facilities, about 70%, were made before 1950. And when you're talking about healthcare, when you're talking about actual, quality of services, when we have some facilities where the ceiling height isn't under code, and the plumbing is sometimes even older than the 50s and everything, we're talking about a health system that needs to be modernized. And so the AIR Commission actually gives us the structure in order to do so, to map out through market assessments the footprint of the health system, and then to present that as a full package for infrastructure support to Congress and then eventually to the White House. This is necessary if any of you really track how Congress tends to act. This is typically necessary that we needed to present it en masse because there's a lot of individual pet projects of different members of Congress where they want to keep this clinic open, they want this project going forward. And unfortunately, it may not necessarily be due to the actual demand, the needs of the veteran in that area. They're making a case perhaps for very different reasons that may be more political in nature as opposed to what's necessary as part of the health system. So the market assessments coming through the AIR Commission would be, argument is will be politically protected if we present them in a single bucket through the AIR Commission, as opposed to needing this sort of appropriation support and infrastructure support to come through Congress one by one, case by case. It's massive. I serve as one of the 3 co-chairs of this assessment. These assessments that we're doing, we've been doing it now for 3 years. The country's broken up into 96 markets, and we are proposing building new facilities, and we're proposing bringing down some other facilities. It's a lot of emphasis on data and demand and services and equity, and how we can actually make sure that the footprint of this health system is meeting the needs of veterans. I mean, one of the things we had to come really full circle on is a lot of the facilities were initially created in very rural, small town areas because when they were built, even early 1900s, some of them in the 20s, the actual philosophy behind medicine was different. When service members were coming back, perhaps with PTSD, perhaps with other mental health illnesses, they back then were looking at medical care as more as a sanitarium sort of approach. Let's move them out from the urban areas. Let's keep them living there on these widespread campuses where they have fresh air and everything. And that we know is obviously not a modern approach to medicine, but yet our infrastructure is still reflecting that. So how do we make sure that perhaps we're closer to our academic affiliates, that we're closer where veterans are actually living now? We have a lot of evidence that shows veterans are nowhere near many of our facilities, but yet we're forced to stay there. And then most importantly, perhaps where we can also recruit the right workforce, because there's some cities, unfortunately, that just aren't sustaining hospitals. Note though, one of my first points about our 4th mission is that we are meant to support the larger public health infrastructure of the United States. So we aren't just making decisions on veteran demand alone. We're looking at where are our trainees actually needed, and where do we need to sustain those programs? Where, from a 4th mission standpoint, do we need to make sure we're supporting the public health infrastructure in certain states? Critical access hospitals are closing left and right. We saw a number of them close during the past year, during the pandemic, just because they weren't able to support services. And does VA need to stay in those areas, not just for veteran support, but larger U.S. healthcare support? So all of that is taken into account in the market assessments, and it's been massive work. And then lastly, under the Mission Act, I'm sorry, it was massive. I feel like this slide is like way too much, but we were finally given a lot more ability, including loan repayment, ability to increase salaries and the like for recruitment and retainment of all healthcare professionals. And that's just something quite necessary. You can imagine, particularly when we're talking about competing for specific parts of the healthcare workforce, when indeed they have private sector benefits that as a federal system we can't necessarily provide. We need obviously the authority to be competitive, and so our ability to truly provide financial assistance and salary support for providers, especially you can imagine subspecialists and things like that, we couldn't necessarily afford on a federal salary alone. All right. So jumping into the eligibility, I won't focus too much on community care, but this was my life for the past 4 years of defining eligibility from the choice program, which was based on a wait time of 30 days or a drive distance of 40 miles. It was very arbitrary how Congress actually put that in the legislation. There was no flexibility whatsoever. So literally, if a veteran that I was seeing lived 39 miles from the facility, could not get referred out to community care. By law, they had to live 40 miles. It was awfully arbitrary. It was just so restrictive. And then the wait time of 30 days made sense, but we actually then pushed ourselves in developing the new Eligibility and Remission Act. We actually think wait time of 30 days is too long. And when we actually did the market analysis of how other payers, how other health systems like Intermountain and Geisinger and all those different organizations were looking at how long should a patient wait for access to care, we actually brought those wait times down. Primary care of 20 days is more the average wait time for specialty care. Everybody's at 28 days. That's just the standard. But then we were looking at drive times as well too. And the secretary at the time under the last administration was really trying to make sure that the experience for the veteran was consistent and didn't want us looking at mileage, because 40 miles in New York is very different from 40 miles in Montana. He wanted us to look at how long would it take? What is the experience of the veteran to get the services that we're providing? So it's meant to take into account traffic. It's meant to take into account changes within a day or so. And so we have a lot of calculations and software built to unfortunately still average. It's not real-time calculation, because when would you do it? Would it be at the time of the referral? Would it be that you had to forecast at the time of the appointment what the drive time was? We ended up doing an average, but it at least takes traffic into account. Initially, we weren't able to, through our technology, build traffic wait times into account. It was more how the crow flies. And so it was, mapped out without traffic at all. So now, veteran drive time is calculated, but then separately. So for primary care and mental health, we think you should be able to receive those services within 30 minutes and specialty care within 60 minutes. So it's really a commitment of the VA. If we can't provide it within that 30 or 60-minute drive time, then you can be referred out to the community. You are eligible, and you can elect to go to the community. You don't have to. And in fact, large proportions of veterans who are eligible for community care don't choose to go because they indeed have a continuity relationship in the VA. They like our services because, of course, we are really, again, that integrated system where we're not just treating one of your issues, but we actually are treating you for your lifetime and across multiple services and states of well-being. And Kelly, I'm sorry, I know you're making comments, but I am so not looking at anything I should be looking at.
No, you're good.
Okay, good.
I am asking questions to you as they come in, and then I've just been adding little anecdotes of my own doing.
Perfect. Okay, good. Yeah, no, stop me if good. Perfect. So then this was just, I put in so much work on this over the past couple of years, but we finally got the new contracts awarded. So the choice program, and then we had the choice third-party administrator. So an organization, we have Optum, which is part of United Healthcare. Organizations actually run these managed care networks, and a lot of, for instance, hospitals that run their own ACOs, accountable care organizations, will hire what's called a TPA, a third-party administrator, to run the network for them, meaning build the contracts, credential the providers, oversee some quality, pay the claims. It's actually quite a standard relationship. Prior to this set of contracts, Community Care Network, again, we had the choice contract, but at the time, I was not a part of it. At the time, they built these contracts where these TPAs controlled every bit of the care. All the VA did was put in the referral. Then the TPA called the veteran, scheduled, chose the provider for them. It was just all out, full out services. We needed it at the time that the choice program was enacted, but it was a huge dissatisfier. VA was taken out of the relationship completely between the veteran and the community provider. And again, like I said, we want to be at the center of that care coordination. We want to be the one integrating all the services, but we had absolutely no transparency to that. Veterans were really dissatisfied with how that went as well too, because of course they do have relationships again with the VA. So with this new set of contracts, we took it more to really the private sector model again, which is they build our network, meaning they contract the providers, they assure their quality, meaning we credential them into the network the same way any other managed care organization would, and they pay the claims. But all the scheduling, care coordination, and any veteran-facing customer service functions, the VA took back. So this was a massive change from the choice program, a huge lift to get going, because that's a lot of work that VA had to take back that had been basically turfed out to the choice TPAs, but now under the CCN TPAs. A little bit of a transition period that we need. They're helping some of our facilities do a little bit of the scheduling work because, we're very different. Actually, this is pretty huge. We're very different from the private sector in that we tend to, unless the veteran truly says they want to self-schedule on their own, we schedule all their appointments for them in the VA and in the community. This is, think about what that means if you go to your own doctor and they give you a referral and you're on your own. You have to figure out who to call. Maybe they'll give you a name. Maybe your health insurance plan will give you a list of people. Usually you're stuck clicking on a website and not knowing anything about them or whatever. No, we in the VA take what some of us call, and I say us because I agree a little bit, a much more paternalistic view. We do all of that for the veterans themselves to help them navigate the system. And I think there's a little bit more of a middle ground that we could strike, not necessarily backing away completely like they necessarily do in the private sector. And of course, there's some referral teams in the private sector that do this, but it's not typically the case. We're very different in this sense. There's some middle ground that facilities are starting to strike, and certainly certain services, they're just saying, hey, here's a list, let us know who you scheduled with. Part of the reason why we do a lot of the scheduling is we are actually responsible for following up with that care and making sure, of course, medical records get back and that we're following up and everything. We really consider our responsibility to close the full loop on the referral, any radiology or lab that we refer out for and everything. So it's a lot more hands-on typically than other healthcare systems do. And we are really responsible for that, honestly, as a payer as well too, on our managed care side of the house. So watching the time, I'm so sorry. I'm just like rambling on and I'm like nowhere near the end. Jumping into our DEI work, we have a massive matrix that we've built over the past couple of years. And I am so proud to say really able to flesh this out and put some real emphasis on this under this new administration. We were doing this last administration, but it was really quite under the radar, as well as once they released the executive order that there was no diversity training allowed in federal agencies, it unfortunately kind of shut down. That being said, thankfully that order got removed immediately once President Biden got in office, and you can tell here we have a slew of different efforts from actual VHA governance. So those of us who are actually the final decision-making body for Veterans Health Administration. I actually am on the D&I committee, but we also have an office of health equity. So separating kind of veteran outcomes, equitable outcomes, and services from diversity and inclusion, meaning internal workforce issues, so recruiting and retaining and the like. We have this new Office of Diversity and Inclusion that we actually created as part of the committee's work over the past year. Again, under the radar, but we're so glad that we were able to get to the point where we just hired a new D&I lead director, and I'm so happy he's there. A focus on assault and harassment prevention is actually part of this, just because unfortunately women veterans do report higher rates of harassment in our facilities, as well as while they, of course, were in service, of course, higher rates of military sexual trauma. But unfortunately, this is a larger cultural issue that we know we need to address, and that we are actively really moving forward with changing culture, changing the conversation. We have a new white ribbon campaign that's focused on just this, because unfortunately, a lot of the assault and harassment are coming from other veterans, not from workforce. And so we clearly need to address this as a larger cultural issue. So a lot of our efforts and drivers, thankfully, again, we've got the new administration and an executive order really focused on racial equity. But so much of our work, I'm not going to run through all of this, is really focused on data collection. We honestly have not disaggregated our data into multiple different demographic information in the past. It was always a veteran is a veteran, and we know that's not acceptable. We know that we need to be able to see what inequities might be present so that we could actually make take some action and intervention. And so that's a major part of this first executive order, as well as the new Secretary's Task Force that he just pulled together, of which I sit as well as my co-lead over the work that we're doing with the executive order. So we're pretty proud to be ahead of at least the other two administrations in VA, Veterans Benefit Administration and the National Cemetery Administration, but still a lot of work to do. Our focus, of course, is not only on veteran outcomes, but also employee inclusivity. Big push on LGBT equity within the health system, as far as not only services. We have a great deal of work that's already been done in that area, but really tracking, again, that data collection issue is critical for us to make sure, again, that inequities are addressed. And we're actually pulling together, I'm so proud to be chairing our new gender transition program, which is really about building a strategy as to how we can actually work with our transgender veterans to actually make sure they get end-to-end services without any disruption and with full coordination of care. So with that, just wanted to jump into our COVID response. I'll go through this pretty quickly, but the idea is that we really were making moves before the national emergency was declared, and really began to shift our mindset, to be honest, about how we needed to approach this sort of national emergency. And by that, I mean, really looking at ourselves as the single enterprise that we are and cross-leveling resources. A lot of other health systems might have done this, but we were able to cross-level not only supply chain needs, but also transition and move beds of services so that we could be appropriately creating units for COVID in different facilities and transitioning veterans to other facilities when they were in for non-COVID issues. But we were also able to cross-level our workforce, and we sent hundreds and hundreds of different workforce to different facilities. We sent them to New York, we sent them to New Orleans when those different waves were hitting in the pandemic. And this just really demonstrated, I think, the best practices and really learning from the front line and being sensitive to their needs from an operational standpoint about how we could best function as a single health system. We've been moving towards really establishing ourselves as a high reliability organization, in the sense that if any of you have taken any high reliability courses or work, down across the bottom are kind of like the 5 tenets of high reliability as an organization. The parallel is often with the airline industry, right? That as you know, devastating as some of their mistakes may be, they are few and far between the number of flights that are taken in every day. And it's because they are sensitive to their operational needs and really learning from the front line. They are completely preoccupied with failure, because failure to them is death. And that is definitely the case, obviously, again, in healthcare. It's about not necessarily simplifying things and finding the easiest path of efficiency, but really being reluctant to consider anything but the right path. Deferring to expertise is also that frontline piece that we learned throughout the pandemic, what exactly our facilities needed, what our emergency room and ICU docs needed, so that we were able to respond and move those best practices across the facility with great speed. We held operations meetings twice a day to start sharing information. We plussed up more than 3,000 beds by just facilities talking to each other across the health system and figuring out how best to do that. We created positive pressure rooms where they didn't exist. I mean, this was an unbelievable response, and at a scale that's really unprecedented, because again, no other health system is as large as we are. We actually expanded our different staff. We up-trained nurses and primary care docs, you know, to move into the ICU. A lot of private systems do that, but we also have these ICTs, and they're equivalent kind of EMTs, but they typically got those services or got that training during their service time, and we started deploying them across our facilities at large numbers as well too, just really maximizing how our staff was assisting throughout the country. And all of this was completely enabled by the fact that we had a communication system that allowed us, again, to learn from each other through regular meetings, but then also share messages, share videos, share different toolkits that we distributed. And I was actually proud to be a part of that group that was really looking at how we were communicating across the system and learning as facilities were attempting one communication over here, how we were able to transition those as best practices to other facilities. I led our moving forward plan, which was about how we were actually going to basically reopen, even though we never closed. So we actually didn't like using that phrase, but how we were going to restart those non-emergent services, because at one point back in April, we did shut down to non-emergent services, so only emergency rooms and inpatient, no outpatient or elective surgeries. But how we were going to move forward from there, we actually developed this full guidebook. It's still being amended today even, because it was meant to deal with the waxing and waning of different waves, how you deal with dentistry, how you deal with group visits and the like, how we deal with changing PPE requirements, right? Because of course, over the pandemic, the CDC has been releasing, you know, refinements. And so all of that is in this one guidebook now. And we actually pulled together a lot of local SMEs, subject matter experts, to help us pull that together. We plussed up, and that was the one thing I think my boss was most impressive about. He actually really foresaw that we were going to have workforce issues more than just staff members actually contracting COVID, but retirements over time, burnout over time. So no matter what, the message every day was just continue to hire. We'll find the funding later. We'll find it later. We hired, I mean, this is unprecedented in a federal agency. We hired more than 58,000 employees in 2020. It's just unbelievable. And that onboarding time, I mean, it took me, 4 months to get started to VA myself. We cut it down to 1 to 3 days, even providers. We had you on the floors immediately if you wanted to come work for us. We just pulled down all barriers. And so much of this was, again, sensitivity to operations, because they were telling us what they needed. They needed the staff. So we in central office were like, let's fix the policy. Let's delay the policy. Let's do whatever we need to get them their needs. Let's be sensitive to their needs and not so get caught up in whatever legislative or regulatory problems that might be stopping us. And so it was amazing response. And then, of course, with telehealth, every health system improved with this, right? But because of our federal supremacy and our ability to we call it anywhere to anywhere telehealth, we increased more than 1,200% our visits, and actually have sustained that. We're looking that's obviously the new normal for most of the healthcare system, but of course, because probably a lot of the private sector payers are going to be reverting back to maybe that face-to-face work, we will probably stay at the lead and not do that, because again, within our own system, offering telehealth or even paying it in our network differently than other payers, I think we're going to really stay at the forefront of how telehealth stays really the expectation. To be honest, we look at it as a veteran satisfier. We look at it as an access issue. Why am I going to make you drive even that 60 minutes when I really can just talk to you over a telehealth visit? We think the rest of the payer sector is probably going to revert back in some way, just out of maybe fear, where for us, our main motivation is to make sure that veteran care is prioritized first and foremost. So we're happy about that. Yeah, I'll keep jumping. Sorry, guys. There's so much here with COVID. We actually started, my good friend, the lead of our emergency medicine service line, Chad Kessler. He's at Durham, if anybody's got any friends down at Duke. He created this like new, just 20-minute Tuesdays and Thursdays, like basically mini grand rounds everyone up to the secretary. I was on it twice. It was just this like best practices. That was one of our communication tools. Just this 20 minutes like blip. This is what you need about COVID, what you need to know about COVID, and everyone listens. The docs, the nurses, the frontline staff. It's just like massive, almost. It's video, but you can just think of it as this massive effort to just share information as best practices and just remain a learning organization so that everyone can really understand. And then in my area now in clinical services, we stood up these cells because we didn't necessarily have a team that was focused and able to really start coordinating across the research teams, across the data teams, across the clinical leadership team on how we were going to move forward with new clinical guidance. So we stood up these quick cells, we call them these task force, to make quick decisions, again, about PPE requirements, about monoclonal antibody treatments, and now about vaccines, obviously, about how we're going to push things forward in a consistent and integrated fashion. And integrated meaning all of the players were together in this one cell to make these decisions and then push it out to the field. So it's pretty impressive how quickly we stood those up and how agile they've been over the past 6 months. So our fourth mission, again, this is just entirely impressive that we've been able to do this. I mean, even in New York City there, we actually converted one of our 5 hospitals to a fully COVID hospital. I mean, you obviously can't do that everywhere, but of course in New York, we have that many beds and buildings. And so we quickly opened those beds to non-veterans. We did the same in New Orleans. We've done the same all across the country. Honestly, the biggest amount of work here was with the nursing homes. We actually, most people don't know, we're more than just hospitals. We have what we call our community living centers. We don't call them nursing homes, CLCs. And we hold them at a higher set of requirements than CMS does for nursing homes. So we have nursing levels that typical nursing homes don't have as far as certification and licensure. The ratio of nurses to veterans is much lower. It's meant to be more really specialized and focused care. And we were able to respond to the pandemic better with all of that expertise in health, and community nursing homes suffered. You know that for a fact. You heard all of the different issues. What you might have heard as far as negativity about the VA, they call them state veteran homes. Those are technically not VA facilities. They are run by the state. We are responsible for helping when they need assistance. So a lot of the drama you heard in the media were with the state veteran homes, not our community living centers, unfortunately. And I even had a classmate from high school whose father passed in one of them. It's devastating. But we continue to offer fourth mission work to the state veteran homes as well too. All right, so that's just a wrap up of really high reliability. If you guys haven't read about that, you know, IHI, all these different organizations in healthcare quality really look at high reliability in different respects. So I definitely recommend you read that pretty closely and just kind of learn. And oh my gosh, we have courses and lectures about that, about how VHA is moving in that direction. But I definitely say, you know, where we are now is this massive effort. I didn't even get to include it on the slide. This massive effort about vaccine administration. I mean, telehealth, of course, is going to, you know, keep us in this new space. But we, 2 weeks ago maybe 3 weeks ago, had the Save Lives Act passed by Congress. So we are not just responsible for vaccinating the enrolled veterans. We are now responsible for vaccinating all 21 million. So any veteran, regardless of eligibility, plus their spouses or their official caregivers in one of our programs. That's roughly about 30 million people. So more than any other health system is responsible for. So we'll be getting the supply, but just think about the public health infrastructure that's necessary to do that, the outreach, the communication, the education, but then the actual staff to administer those vaccines while we're still providing care within our facilities and while we're still working on our fourth mission goals to assist other needs throughout the U.S. So we are definitely shaping the U.S. healthcare, I would say, in more and more innovative ways. And it's exciting to be a part of it. And we'll be using all of these lessons learned to continue to improve our own health system, because, of course, nobody's had to respond to anything like this since 1918, right? So there's plenty for us to continue to implement and improve upon. But with that, I'll shut up. I'm so sorry, Kelly, 5 minutes.
No, you did it. You did it. Thank you, Dr. Matthews. This was I even was taking notes and learning things in this talk. As UC Irvine medical students, we rotate through the Long Beach VA. And so I think this is super relevant for
Okay.
all of us here who are UC Irvine students and beyond, because there's VAs everywhere. You're more likely to
Yep.
interact with a veteran than anything, no matter what state you're
Yeah.
in. So we welcome
Yep.
any questions in the chat box here. Feedback for this session is now open. Reese has dropped the link in the chat, but he can again. Any questions for Dr. Matthews on the VHA or the Department of Veterans Affairs? I know I personally have one. I think one of the major critiques around the VA is that it can just be frustrating to work within. You've talked about a lot of modernization pieces, a lot of work that's being done in the VA to fix some of that frustration. What still frustrates you in your role?
Yeah, I think probably the same level of frustration that you all may have there at Long Beach or something, that we are still a federal system and all the bureaucracy that entails. Luckily, I'm at a high enough level when I start facing that bureaucracy, I just kind of am able to go around it, but that's because I'm kind of at the top. But it's is definitely frustrating. And that's why I am just still in awe of how we were able to respond during the pandemic and make those hires and get people in and cross-level supply. I mean, because honestly, pre-pandemic, it would have been, oh, but you need to make sure you pass this money order or transfer this and do, like all the crazy paperwork you think of that, surrounds any typical health system. You can imagine that would have stopped all of that. But we thankfully had leadership enough that said, no, people will die if we continue in that sort of path. So I think we'll learn from there. I think the other frustration, to be honest, and this is something we're working on, part of the modernization, I talked about this at all, is modernizing central office. So like our headquarters where I am, we are not structured in central office like a health system is. So they technically just created the chief medical officer role 2 years ago. They didn't have a clinical lead. Now we have a chief nursing office. Credentialing of providers, quality, two things that typically fall under the lead doc, fall under someone else, because this health system wasn't created at the central office. Like a health system is built like a government agency. And so just like these offices were stood up and it just wasn't organized well and everything. So we're partially there. There's going to be some more efforts, but we'll see. It's going to take some time. And then lastly, and I know this is a lot, this EHR work that I'm doing, this is difficult because the one thing you may have heard, even though we are one system, we were able to integrate and act as one over the past year, the phrase you always hear is, you've seen one VA, you've seen one VA. We are technically, not legally, but the way we act, a federation. Every VA does its own thing. We are moving from 130 different EMRs to one. Every EMR was customized for that facility by that workforce. We are now moving not only to a single enterprise solution, but one that can't be customized because we're buying it off the shelf. So the sheer massive change management that I had to manage over the next couple of years, and just the sheer, I think, frustration that we're going to have to deal with is scary for me. But that's also what frustrates me, that we still have to convince people, even though we saw the example during COVID, that being one enterprise is actually better for veterans. It gives them a consistent experience. It gives us the ability to actually have efficiencies that one facility alone can't provide. So that's kind of frustrating for me, that there's still those naysayers out there that it still should be one VA and one VA alone, but sure. We'll fix it.
A last question here before we move into our next session with future Dr. Ngumeni Tiako. A question that was kind of a unifying theme of a couple different questions that we got was really, how can a community member, a medical student, really be involved in helping impact this vulnerable population in the context of COVID or otherwise?
Yeah, I think honestly, first and foremost, especially in your training, come do rotations with us. Like, I mean, we have affiliations with pretty much every medical school. You guys go there to Long Beach, choose VA, and just learn first and foremost about military medicine and veteran care and what it is to really understand what care is like from their perspective. Because I think, again, that's not something that is typically the emphasis within the private sector. A lot of times you're in this fee-for-service sort of world where it's just about, billing and coding and all the different stuff, and just worrying about the silo that whatever doctor you're shadowing or working with is focused on. We're in VA, hopefully all VAs. I can't speak for Long Beach, so I don't know the same, but the idea is that, it's supposed to be putting the veteran first at all times. So I would, more than anything at this point in your training, just come and work with us, see what it's like, but don't get frustrated if Long Beach is that bad, because I can't even speak for it. But my friend is actually possibly going to be the COO there. I hope he gets hired from Chicago. He's going to be there. And so you guys might have a really good advocate there. When he gets the job, I'll pass his name on. He's really good. I'm happy he's going to Long Beach.
I'll take it. If you have other questions for any of our speakers, but namely for Dr. Matthews, by all means, contact us and we'll get those answered for you. Thank you so much for being with us today, Dr. Matthews.
You're welcome.
This is very, very
and I just
solid.
dropped my email. Please.
There we go. Okay.